Vanakkam. Whenever we see a child that has been born with fused fingers, we always think of the diagnosis of congenital syndactyly. But there is a very curious condition where it is not congenital syndactyly. It is another condition called acrosyndactyly. You will note that these fingers are fused towards the tips, the finger webs may be present, one or two fingers may have been amputated, one or two fingers may be swollen, and one or two fingers may be even deformed. This curious condition called acrosyndactyly is very interesting, mainly because of the etiology and the management protocols. Let us have a look at acrosyndactyly to see what it is and how it is managed. Acrosyndactyly is a congenital malformation of the hand which is usually caused by a condition called Constriction Band Syndrome or Amniotic Band Syndrome as it is sometimes known as. Before we learn about acrosyndactyly or Constriction Band Syndrome, we need to understand one basic point. When the hand is formed in the embryo, first the hand pad is formed, then the fingers separate, and this separation of the fingers occurs from distal to proximal. So if you find fingers that are fused but proximally you can see the finger web spaces, it means that the fingers had separated normally up to the web spaces but they got fused again later due to some problem which we shall see in this video. This shows the example of how the fusion has occurred distally after the fingers had separated. Even if you cannot make out the finger web spaces completely, you can make out some small sinuses which are communicating between the volar and the dorsal sides, as demonstrated in this picture. The Constriction Band Syndrome or the Amniotic Band Syndrome refers to partial or complete circumferential constrictions around the limbs or digits. As a consequence of these constrictions, acrosyndactyly of digits may develop, terminal absence or amputation may occur, localized swelling with digital edema distal to the constrictions, or just a constriction band may present. This condition has been classified as constriction ring sequence as a deformation in the OMT classification adopted by the IFSSH in 2014. You can click on the link above to see a more detailed description of this classification system. Fibrous bands of the amniotic membrane get tangled around a developing fetus which can wrap around the fetus's head, umbilical cord, arm, leg, fingers or toes. This can cause serious constrictions or tightening, acting like a tight rubber band around the body part. But what causes these bands? There are three different proposed theories to the cause of the constriction ring syndrome. The first theory is the intrinsic theory proposed by Streeter in 1930. He believed that it was an anomaly in germ plasm which results in the defects, and vascular disruption leads to amniotic bands. The evidence that supports this theory is that clinical presentation of the constriction rings can be seen with other internal visceral and systematic anomalies. This theory was quite popular, and constriction band syndrome itself was known as Streeter's dysplasia for quite some time. The second theory, proposed by Turpin in 1965, said that it was involvement of an intrauterine disruption during pregnancy followed by a cascade of events involving amniotic rupture. When spontaneous rupture of the amnion occurs early in the second trimester, the separation of the amnion from the chorion produces many small thin strands that can become entangled within the digits and toes. Later, as the fetus grows, but the bands do not, the bands become constricting. This constriction reduces the blood circulation and hence cause congenital abnormalities in the growing embryo. The exact mechanisms by which these bands produce the malformations was described by Higginbotham in 1979. The first was interruption of the normal morphogenesis, for example, at the time of facial fusion process. The second was deformation due to compression of parts of the fetus or interlacing of an anatomical part of the fetus by a band. And thirdly, injury to a part of the fetus that had already formed, like in the cases with constriction rings around the limbs. The third theory about how these amniotic bands form relates to intrauterine trauma like amniocentesis or a fetal surgery. An intrauterine trauma could result in hemorrhage leading to acrosyndactyly. One study also showed the presence of bands as confirmed by sonography after fetal surgery. The diagnosis of this condition can be made in the prenatal period or after birth. In the prenatal period, the presence of acrosyndactyly or mainly the constriction bands can be confirmed with an ultrasonography, which is done at the end of the first trimester or at the beginning of the second trimester. However, we need to remember that not every patient will be diagnosed at that particular moment. That is because individual strands are small and hard to see on ultrasound. A 3D ultrasound and MRI may make it a little clearer. These pictures from literature show three-dimensional ultrasonography in rendering mode, showing amniotic bands adhering to the right forearm of the fetus without constriction rings. Prenatal diagnosis can also be made indirectly by the presence of decreased fetal movement, of which one of the causes is amniotic band syndrome, and the second is the strong relationship between amniotic band syndrome and club foot, which occurs in almost 31.5% of children. After birth, the diagnosis is quite simple but sometimes confusing because of the different ways in which acrosyndactyly can present. It could present only as a dent around the finger or limb, as seen here. We can make out three bands, two at the level of the elbow and one at the level of the lower arm. It could present as a serious swelling to the part of the digit or hand distal to the constriction band. Here you can make out the constriction band on one finger and swelling of the distal part of another finger. Sometimes there may be a restriction of blood flow leading to growth deformities distal to the constriction bands or necrosis and secondary healing. Here the fingers had formed normally in the fetus, but amputation of the tips of the index and ring finger occurred along with the raw areas on the middle finger, which all got fused together during the growth of the fetus. Or acrosyndactyly could present with amputations when the blood flow has been totally cut off to the digit or the limb. We need to remember that the child may present with all of these features in the same hand. So acrosyndactyly is a complex collection of asymmetric congenital anomalies in which no two cases are exactly alike. So that makes classification of acrosyndactyly difficult. The most widely used classification system was proposed by Patterson in 1961, and this was based on the severity of the syndrome. And there are four basic types. Patterson type 1 consists of simple constriction rings. The thumb is not likely to be affected by this type because the thumb is usually kept adducted within the palm in the fetus. In the second type of the Patterson classification, strands which obstruct the lymphatic vessels leading to fluid retention with distal swelling of the affected extremity is seen. In Patterson type 3, there is a complex form of syndactyly named acrosyndactyly where the fingers were initially separated, but due to the constriction they are formed back together. Sometimes multiple fingers can be involved. The distal fusion between the digits never initially involve a skeletal coalition, and normal neurovascular bundles are not present in the distal parts. There are three subtypes to the Patterson classification 3, which refers to acrosyndactyly. In subtype 3A, the tips of the fingers are joined. In 3B, the tips are joined but the webs are too distal, and in type 3C, the tips are joined, there is no web space seen, the bones are also joined, and there is a proximal sinus. Patterson type 4 classification of acrosyndactyly refers to one of the most severe consequences of constriction bands, and that is intrauterine amputations of the digits. This is where the constriction goes as deep as the bone and cuts off the blood supply of the distal extremity. The result will be that the developing finger will become ischemic and fall off. And because the result is a transverse amputation at the level of the constriction band, the actual constriction ring is not seen in these cases. There are three different outcomes following Patterson type 4 acrosyndactyly. The first is complete resorption. This is the most common form of amputation. In this form, the amputated digit is completely resorbed during the intrauterine development, and therefore the amputated digit cannot be found. The second is recovery of the digit. The digit is recovered with the placenta during delivery. And the third is engraftment elsewhere. The amputated digit can be, in rare cases, engrafted somewhere else on the fetus. The differential diagnosis of acrosyndactyly is quite important. It could resemble a symbrachydactyly, hypoplasias of the hand, digit or thumb, Adams-Oliver syndrome, where there are transverse amputations of the digits associated with congenital skin problems of the scalp, or the ADAM complex. This is an abbreviation for amniotic deformity, adhesions and mutilations. This is usually an association of limb defects caused by constriction rings with craniofacial defects also. Obviously, when there is such a plethora of presentation, we cannot have a single management protocol. However, we need to understand the principles behind the management of each of the problems. So we shall deal with the management under the headings of management in the prenatal period, treatment of digits threatened at birth, nerve palsies, constriction ring per se, acrosyndactyly, skin protuberances, absence of the digit, and thumb problems. The opinion of surgeons is sometimes sought in the prenatal period when the diagnosis of constriction band syndrome is suspected. So we need to understand about the prenatal management of this condition. In utero release of limb constriction rings has been performed successfully with preservation of the limb. However, there are risks to the mother and child like premature delivery and spontaneous abortion, which could occur in 6% to 10% of the mothers. Fetoscopic surgery is still an emerging technique. It is right now limited to progressive edema and loss of circulation that likely will result in loss of limb. Sometimes the child may be born with the limb or digit threatened at birth. This is due to the circulation being compromised by the lymphovenous tunicae effect of the constriction bands. Segmental band release, similar to an eschorotomy, to decompress the constriction and restore circulation may have to be done. In rare situations, peripheral nerve palsy underlying a constriction ring may occur, and this has to be based only on clinical assessment because electromyographic studies have not been proved to be useful. This example shows a radial nerve palsy occurring in a child with a constriction band of the arm. But the results of such decompression for nerve palsies have been variable. So a study also concluded that resection of the nerve and reconstruction may be a better and predictable option in such nerve palsies following constriction band syndrome. Management of the constriction ring per se is needed for both functional and aesthetic improvement. This is usually achieved with a Z-plasty or a W-plasty, where we are able to elongate and reorient the band or scar to allow relaxation and concealing of the constriction. The basic principle of this surgery is to correct the contracture within the subcutaneous layer. Markings are made to excise the band and multiple Z-plasties as shown in the diagram, and the elongated and reoriented direction of the scar is seen with good healing and reduction of the distal lymphedema. While excising the band, the incisions are made on the skin down till the depth of the constriction band, and this is excised along with a little of the subcutaneous tissue so that there is a redistribution of the subcutaneous tissue and correction of the contour. But what about the timing of release? When there is severe lymphedema, the release can be done as early as possible when the child is fit for the anesthesia. Previously, circumferential surgery was not recommended as a single setting. However, complete circumferential excision may be performed safely in certain conditions where the constriction band is not going down to the bone. Another exception to circumferential surgery is two rings that are closely adjacent to each other. In this case, it is prudent to release the rings one at a time. When there is an acrosyndactyly, they need to be separated according to the principles for reconstruction of syndactyly. You can click on the link above to see the details regarding the principles of syndactyly release. But there are some important salient features which differ from the regular congenital syndactyly. For instance, the recreation of the finger web, resurfacing of the digital surfaces, and management of the nail and pulp. The use of full thickness grafts should be advised wherever there are digital raw areas. Sometimes there are skin protuberances, and these lumps of skin are present on the dorsum of the fingers and appear firm and edematous. Z-plasty can be done, but it is often unsatisfactory. Excision with primary closure or resurfacing with full thickness grafts is usually the preferred management for these skin protuberances. Digital absence due to amputation is common in constriction ring sequence. The number of absent digits is variable and it resembles a transverse absence. Reconstruction can be done according to the principles of reconstruction of amputated digits or short digits. These are discussed in the segment on reconstruction of the thumb. The classical feature of thumb involvement in constriction band syndrome is hypoplasia. The hallmark of this hypoplasia is that the anatomy proximal to the level of amputation or level of congenital amputation is normal. Management of thumb problems involve four principles. The first is immediate treatment of emergency conditions such as vascular compromise and progressive lymphedema of the thumb. The second is early liberation of the thumb ray from an acrosyndactylous complex. So if the thumb is fused to the other fingers, usually the index finger, this release must be done as early as possible to allow the thumb to grow normally. The third is release of adduction contractures within the first web space when present and resurfacing with full thickness tissue if needed prior to any augmentation of thumb length. This hand shows a hypoplastic thumb with a very narrowed thumb web. The narrowed thumb web in this child is going to be released and deepened by the square flap technique. You can click on the link above to see the details of the square flap technique. This picture shows the flaps after the square flap incisions have been made. The postoperative result shows a good wide and a deep thumb web. The fourth and important principle of thumb reconstruction in constriction band syndrome is augmentation of the thumb length. This can be achieved by one of the following three methods: distraction lengthening at the metacarpal level, non-vascularized toe phalangeal transfer, or composite vascularized toe to thumb transfer. Distraction lengthening is best performed at the metacarpal level when satisfactory bone stock is present. The metacarpal can be easily but slowly lengthened up to 100% of its length, and it may have to be done as a two-stage procedure that includes application of the distraction apparatus and osteotomy in the first stage, followed by bone grafting of the intercalated gap and internal fixation if necessary in the second stage. Lengthening of deficient terminal and narrowed phalanges in this condition is not as predictable, and the resulting digits are often stiff and thin. Hence, distraction is not ideal for the phalanges. Transfer of non-vascularized toe phalanges provides length and growth potential to an empty redundant soft tissue envelope, which is occasionally seen distal to the level of amputation in this condition. Extra periosteal harvest and transfer of the third or fourth toe proximal phalanx will result in survival and growth, especially if done under 2 years of age. The second toe is paired so that the entire toe may be available for vascularized composite transfer if required. The use of vascularized toe transfer, usually the second toe but sometimes the great toe where a wraparound toe flap can be done, is ideal for amputation through the proximal phalanx or the metacarpal. This can yield excellent functional and aesthetic results as seen in this series of pictures where a vascularized wraparound great toe transfer has been done. I hope you liked the video. I enjoyed making it. Please do click on the shown links to see more about radial club hand and its management. And do not forget to subscribe to stay connected with the latest in learning, hand surgery, trauma surgery, plastic surgery and ethics. Vanakkam.